Okay, thank you very much for joining me at this seminar about global health and inequality and the role of health research diplomacy. And we are so lucky here today that we have with us Professor Ole Fridtjof Nohe and Alicia Ali Yamin, who both have extensive experience that is very relevant for understanding this subject. The seminar will take the form that we have an informal conversation where I will ask you some questions, and afterwards we will open for questions from the public. And of course you can comment each other if you want to. Since Bergen Exchanges is organized in collaboration with BSAPs, I will first introduce Ole Fridtjof Nohe, who is the director of the center. And you are the professor of medical ethics at the Department of Global Health and Primary Care at the University of Bergen. And you're also an adjunct professor at the Department of Global Health and Population at Harvard T.H. Chan School of Public Health. And you are currently the director of the Norwegian Biotechnology Advisory Board. And you have been a member of several Lancet commissions, but including one, the one that's called Lancet NCDI Poverty Commission that is launching their report in the midst of September. I'll get back to that. Okay, but you have also been the chair of the World Health Organization Consultative Group, and you have actually published more than 180 peer-reviewed articles, but including articles in The Lancet and BMJ, which is very top-notch. So this varied background gives you, I think, a very, very interesting viewpoint for discussing these subjects, because you have so various experience. But first, why don't you tell us a little more about BSAPs, which is an abbreviation of Bergen Center for Ethics and Priority Setting, right? Tell us a little more about it.
Thank you very much for this nice introduction. So I'm a medical doctor and I started to do clinical medicine, but I soon realized that if I wanted to make some difference, moving to global health and moving to public health was important to me. So we have now established the Bergen Center for Ethics and Priority Setting here at the University of Bergen. And we are more than 20-30 people working almost day and night to improve priority setting, both in particular countries and globally. And we have this slogan that we want to improve priority setting so that health and healthy life years is maximized, fairly distributed, and with financial risk protection. So that's kind of our vision. And we work in particular in 3 countries, being involved in supporting universal health care coverage reform. So we are involved in defining benefit packages, what to prioritize within scarce resources in an efficient and fair way in Ethiopia, in Zanzibar, and in Malawi. So that's basically what we do. We have a lot of very good young researchers, master students, PhD students from all these countries.
Okay, that's great. Very ambitious and great. Okay. Now, for those who don't know this research area so well, could you just please explain what we mean by global health and inequality, and what are kind of the overall patterns of inequality in health?
Yeah, so health inequalities are very present just now because of COVID, but of course we have seen this and know this pattern for forever in many ways. So if we first think about global inequalities in health, there are substantial inequalities in, let's say, life expectancy between low-income countries and high-income countries. It might be a difference between 10, 15, or 20 years. So that's one type of inequality between poor and rich countries. And then within countries, we also see equally big differences among the low-income people or marginalized people, people living in rural areas. They typically have lower health life expectancy, more illness and disease than those better off. And we also know a lot about the mechanisms for this. We know that all the determinants of health, like poverty, social status, gender, ethnicity, a lot of these mechanisms shape the life chances of people in terms of health. And there are also the political determinants, of course, that shape the distribution of well-being, of income, that also affect health. So these patterns are well established, and what we do in our research is to think about and propose what can be done. So we are very eager to look at policies and improve health systems so these inequalities in health can be reduced. And if I may say so, I see three alternatives to improve health inequalities. You can start a revolution, so you get a more equal distribution of the determinants of health. Or you can elect the right leaders and influence policies through democratic means. And you can, as a researcher, influence the choices that are made within the health system and within the political system. Because there are a lot of choices that we make on how to allocate resources, how to form the healthcare system so that it can become more fair and more equitable. And I would say that we are not so much revolutionaries, but we try to think about democratic mechanisms, but also improving the health system and providing evidence for better policy decisions.
Exactly. Okay. Is that the Lancet Commission that you're currently a part of? Is that related to this topic on inequality? And what suggestions are we making there?
Yeah. So these Lancet commissions are commissions put together by experts in different fields. And this particular commission is called the NCDI Poverty Commission for the Poorest Billion. And NCDI is an acronym for non-communicable diseases and injuries. And it signals a kind of shift in global health, because traditionally we have been concerned about maternal health, child health, and infectious diseases. But now countries are developing and people live longer lives, and we see an increase in the number of chronic diseases. And many poor people in low, but a majority lives in the middle income countries. They also die of cancer, of cardiovascular disease, of chronic diseases, mental health. And this commission is set up to focus on that, to produce the evidence and the argument for strengthening healthcare system provision for the poorest billion in the world, to improve access to these very important services.
Okay, very important. Okay, you have mentioned some of it, but could you also tell us a little bit about both the causes and the consequences of health inequalities? You have mentioned some, but are there something you would add?
I think the understanding the determinants of health and also thinking about the linkage between health and income, job security, for instance, and it goes both ways. So one example would be now COVID, the pandemic affecting the US. And when we see now that the pandemic is affecting employment in the US, hundreds of thousands, maybe millions of people are at risk of becoming unemployed. And because they have designed the healthcare system in the US in a way that is linked to employment, the effect of a disease like this is actually that they lose health insurance, and then they lose access to good health care. So these determinants of health affects health in a very substantial way. And when we see also that poverty increases in many countries because of the pandemic, we also know that that will affect the people's access to health services and finally their health outcomes. So it's closely interlinked, these determinants of health and health itself.
Exactly. So it must be understood.
And that's why it is a concern for us who are concerned about equity and social justice.
Yeah, of course. because it's so in order to understand health inequality, you must understand other types of inequality in the society.
Absolutely. So that's why we also need to be interdisciplinary. We need to understand politics. We need to understand demography. We need to understand economics and anthropology, understanding how people get marginalized, all these mechanisms that shape our life chances.
Exactly. Okay. So how do researchers investigate this topic of health inequality? Because it's a very big topic. So how could you please just give some examples from your own research?
Yeah. So in many low-income countries, we actually have very good data on inequalities in health, because there's something called the demographic health surveys, where they collect data every 5 years on the determinants of health and on health indicators like access to services and so on. So these kind of data sets we use to kind of document inequalities in health and try to understand the mechanisms. But we also use that for monitoring improvements. And I must say that we see a lot of improvements in many low-income countries, that health indicators have improved a lot in the last 10, 15 years. And we also see in many countries reduced health inequalities. Some inequalities are widening, but for most countries we see that there is a reduction of health inequalities. And we use this kind of evidence and data to also do analysis to think about how could we accelerate this improvement in health inequalities. And we strongly believe that by improving health services, and making them more equitable, that will improve health inequalities. And I've been increasingly concerned about how health systems are shaped and how they are financed. I've grown up in the Norwegian healthcare system, where we have universal healthcare, and we take for granted that society think that health is special and important. So it's free when you need it. But that's not the case in many countries. So when you don't have fair financing of the healthcare system, it translates into more health inequalities. And that's one of the things that we try to work on advising on how to develop and improve the health system with better financing mechanisms so it can be made more equitable and fair. And that will involve both elements of the healthcare system, but also we need to collaborate with people who knows more about taxation, how to develop health insurance systems better, etc. So we try to attack this problem in many different ways.
I see. Okay, and one of the resources that's very relevant today is the distribution of COVID vaccines, when we get them, hopefully. So can you say a little more about that, because you have been involved in it?
Yeah. So this summer I've met regularly on Zoom with a group of international scholars, mostly ethicists and some economists. And we have started to write a paper that we hope will influence the debate about how to allocate a vaccine, if it comes or when it comes, in a fair way across countries. So we hope that there will be some vaccine that might be effective and protect people maybe at the start of next year. There are many, many different groups working on and testing out vaccines. And we see especially two big problems. One is what is called vaccine nationalism. So some countries have made agreements with these companies that are developing the vaccines that they will have first access to these vaccines. But we know that the capacity in the world to produce vaccines will be limited in the beginning. Just having these small glasses where you put the vaccine in, they don't have enough of these, and all the elements that go into vaccine, the production capacity is not big enough. So if we are very optimistic, maybe there might be 1 billion doses available throughout 2021. But that means that if the US, for instance, get access to 350 million doses, there will be 650 million doses to the rest of the world. And we discuss in this paper what is the acceptable limit, because there are agreements between these companies and some countries, and if one company is within one country, we expect that this country will have access to this vaccine, and there are arguments for why it should be like this. All country leaders will fight for their primary constituencies first. But we argue in this paper, and we discuss this, that maybe we shouldn't accept that they can cover the whole population, but maybe up to a limit, maybe up to herd immunity, for instance. Let's say 70% of the population, or maybe 50%. But the rest then should be distributed in a fair way. And there's a lot of countries and WHO and CEPI Alliance, this alliance investing in COVID vaccines. They have argued that there should be a mechanism for equitable distribution. And the big question is, what does it mean? Should every country have the same amount of vaccines or in proportion to population size? Probably no. So what WHO have proposed is that vaccines should be distributed according to the number of health professionals, because they are crucial they need to be protected, and they are crucial in providing the vaccines. And it should also be distributed according to the number of high-risk patients, those who need that most. And this seems to be very plausible criteria. But if you think about it, and we have discussed it a lot this summer, this will favor the rich and well-off countries, because you have far more health professionals in a country like Norway or the US than in Ethiopia, for instance. So it would disfavor those countries. And because of the age distribution, many of the high-income countries have many more old people and people with a lot of comorbidities. So in a sense, it's right, they need it more, but it could actually increase the inequalities in health if we distribute according to these criteria or principles. So we have discussed alternative principles, and we're kind of roughly recommending what I earlier said was the vision for BICEPS also, that we need to maximize healthy life years for all, but with a particular emphasis on equity and the worst of countries in this respect, because since there are large inequalities between countries, we think that we need to include a criterion of what countries are worse off than others. On top of that, you also need to think about productivity. So COVID is affecting economies everywhere. So you have to save lives and you have to stimulate the economy. And then there will be a trade-off between should we only think about the health outcomes, or should we also think about stimulating the economy, prioritizing the productive part of the population? Maybe that would be unequal regarding women and men, old and young. What about school children, thinking about the future of their well-being and training and intellectual development? So there are a lot of very hard choices to be made in thinking about which groups should have priority and how does this translate to fair principles across countries.
Wow, that's...
And I don't think we have all the right answers,
no.
But I do believe that stimulating this debate and putting it out for wider discussion is important. Yeah. And we believe that having some critical voices to the dominant approach in the WHO is important as well.
Yeah, I agree. And I think this is much more complex than I thought of before you talked about it. So that's very, very interesting. Okay, the last question is about your experiences with getting political impact from your research. And I guess that COVID vaccines are one issue or one way of doing that, but are there like other examples from your experience of things that either has worked or has not worked, so that younger scholars can...
Yeah. So I think everyone who work in academia or are activists or want to improve the world would like to see some impact of what they are doing. And I think there's one person now in Norway who has this possibility to have an impact on the global development of vaccines, for instance. So yesterday, you probably heard that Norway have announced that Jon Arne Røttingen, the former director of the Norwegian Research Council, who has worked a lot on global health, will be the Norwegian ambassador for global health. And that's a role where he can influence CEPI, that he was responsible for coordinating and setting up that very important organization. He has advised WHO, he has advised the Norwegian government. Those kind of people who can influence decision makers at the international level, they can also influence how decisions are made. And I think we all, to some degree, try to do something like this. Not at that level, but Alicia and I, for instance, we have worked with WHO, sitting in different committees, making arguments about equity, making sure that when they make recommendations that they take equity, human rights, social justice into account. And in different ways, we try to influence decisions. And I think all of us, by producing evidence, publishing our research, engaging in debates, we are all small part of the big puzzle that together provides the information and the arguments and the thoughts and the criticism that shape the public debate and that shape decision making.
Thank you. Okay. Perfect. Then I will move to Alicia. Are you with us, Alicia?
Yes.
Yes. Perfect. Thanks. Okay. So Alicia Eli Yamin is currently a senior fellow at the Petrie Flom Center for Health Law Policy, Biotechnology and Bioethics at Harvard Law School, and a senior advisor on human rights at Partners in Health. And you're also the research leader of the Gender, Sexuality and Law Unit at the Center of Law and Social Transformation here in Bergen. And you're also a member of BSAPS, actually, and also an adjunct lecturer on global health and population at the Harvard TH School of Public Health, and an affiliate of the Department of Global Health and Social Medicine at Harvard Medical School. And you two, Alicia, have a lot of different experience, and I'll come back to that in a while. But first, I just wanted to mention that you have also published many articles, over 100. But your latest book is this one, which is called When Misfortune Becomes Injustice. So I thought, why don't we start with, maybe you can tell us a little more about the book and why you wrote it, and also how it's related to the corona pandemic.
Okay. So thank you for inviting me to be part of this dialogue with Ulle Fritjof, who it's always great to see. Why I wrote the book. I guess to take a step back, I would see, so I have been both in advocacy and academia, but not just public health, but also law. I maybe have a slightly different perspective on the structural drivers of health inequities, which I guess we can talk about later, and I can just answer your question about the book. I essentially wrote the book because I had written another book about human rights frameworks for health and why they matter. And I believe that long before coronavirus, it was pretty starkly apparent that human rights praxis was not on the right path, that we were not asking the right questions. And I think that's an important consideration in research and in having political impact of research. And so I wrote the book setting out sort of the challenges that I saw from the time I was in law school about applying human rights frameworks to health. And the short summary is that I recount how we've made quite a bit of progress in developing health as a legal enforceable norm. We've similarly made some progress in articulating what are so-called human rights-based approaches to health that are meant to make policymakers and different constituents act differently in terms of budgeting and programming, et cetera, and monitoring and evaluation, as well as think differently. But we have not made progress in terms of creating more egalitarian social orders. So the book is really a reflection on why that is. And it's a reflection based on a lot of work in countries where I've lived over the years. I've lived in almost 10 countries over my professional career, and played a lot of different roles.
Thank you. That's very interesting. Okay. You are trained in both law and public health at Harvard. And also, like you said, you have experience not only from academia, but also from social policy, like Lancet commissions, and also the WHO. And also, you have been appointed by UN to work with SDGs. But in addition to this, like you have worked closely with activists, and you have lived, like you said, many years in Latin America and East Africa. So I was thinking, with this background, I kind of believe that you have seen health inequality from many different angles, both professionally and geographically. So from this view, could you please say something about how the topic of global health and inequality is related to law and regulations?
Sure. So I think that inequalities in global health are structured, this is a simplification, but largely by four interlocking structures of power. One is colonialism, two is patriarchy, three is biomedicine and biomedical frameworks, and four is creeping and ever more intrusive neoliberal legality and institutions and governance. And so using human rights to try to advance health equity has had to confront all of those different interlocking systems of power. And all of those present themselves in different ways in the field or in litigation or whatever. And so I guess the way that law interacts is that really over these years, just as we were, thinking that human rights was a way to enlarge our legal imaginations, so too were institutions basically, reconstructing entire legal fields, whether it's antitrust or whether it's intellectual property or whether it's financial deregulation or whether it's taxation. And that had a contradictory effect on whether we could actually make progress toward using human rights to affect social change and bring greater equality. So much of the research that I've done or advocacy that has had political impact is looking at those one or more of those four interlocking structures of power from a different angle. And I'll give you an example. So I was very privileged to be involved in a paradigm change early on in my career on maternal mortality, where previously people had thought that you need to prevent and predict severe obstetric complications through prenatal care, for example, clean birthing kits. And there was a paradigm shift in many ways driven and led by Alan Rosenfield and colleagues that I was privileged to work with at the time, toward emergency obstetric care as a keystone intervention. So that was based on empirical research, largely in West Africa, actually, but it was also based on looking at those structures of power from a different angle, seeing that women were the recipients of a lot of interventions that they were not the beneficiaries of, normatively changing our idea of women as subjects of dignity as opposed to instruments of reproduction. Similarly, I was involved early on in the HIV/AIDS litigation in South Africa. I did an amicus in the Hazel Tao case in the competition tribunal. And that litigation was very important, along with the Pharmaceutical Manufacturers Association case and the prevention of mother-to-child transmission case in the Constitutional Court, because the premise was to challenge the construction of a disparate series of rules that had suddenly been constructed as intellectual property, and the way antitrust and anti-competition was being perceived in that field. And to think that actually this is not something where the law doesn't naturally just defer to markets. The law structures markets and structures fields. So to argue that actually this is a matter of dignity and constitutional rights in the South Africa at the beginning of the millennium. Maybe that was not coherent for the audience, but the point, I think, is that the questions we ask and the lenses we bring to the research have a lot to do not only with the impacts of the research, but also with the potential for coming up with new answers, with breaking out of the kind of the boxes that we are in global health and development.
Thank you. Okay. Maybe may you say something more about what are the drivers of the legal development? Like what causes change in this field?
So I think there are synergistic factors there too. In the 1980s, law and economics was sweeping the United States. And because of the role of the United States in different multilateral institutions, that had an outsized impact. But it was also a time when institutionally and in development, we had sort of decided that the Washington Consensus was the way to go. Governments where the IMF and the World Bank had solved kind of temporary balance of payments problems, then really began intervening far, far more in countries' economies through what's now called structural adjustment, or the menu of reforms according to the Washington Consensus. And over time, from the 1980s into the 1990s, when the GATT became the WTO, which has binding enforcement power, and there was more financial deregulation and antitrust laws changed, all of this had enormous effects on the structural abilities of countries to control their fiscal space, their economies, and the factors that affect social determinants of health.
Exactly. And from that, I also wanted you to maybe, like, how do you do research on this topic? And I was also wondering how because you have worked in collaboration with activists or such environments, and I was wondering how that would influence your research, or if it does in any way.
No, it absolutely does. And I'll give you an example. So I now work at Partners in Health, which many of you may have heard of. It's a global health organization. We have a number of sites across sub-Saharan Africa, as well as in Mexico and Peru in the United States. We now have a number of sites as well, and we're doing accompaniment with some state governments, as well as in Navajo Nation and Immokalee migrant workers. I, for example, sit with a civil society group that looks at access to diagnostics, therapeutics, and an eventual vaccine for COVID-19. I think that you know, it would be great if the allocation of an eventual vaccine were done according to ethical principles and set out that way. Already now, we know that high-income countries have made deals with a bunch of these different pharmaceutical manufacturers, and they're not all the same. Moderna should not be put in the same category as AstraZeneca. I mean, there are different behavior patterns among the private pharmaceutical manufacturers. So it's unlikely. I mean, what CEPI will have, what Gavi is going to have to distribute to low-income countries is not going to be very much. They're going to distribute equitably the crumbs that are left over after high-income countries, and some middle-income countries actually now are going to probably get the vaccine. If not immediately, when high-income countries do, reasonably quickly. That is an issue of structuring institutions and law as much as it is of sort of ethics and policy. But there are there are clearly a lot of those interlocking structures of power working against an equitable allocation of an eventual COVID vaccine.
Exactly. Yeah, that's very interesting. Okay, and how do you think it's possible, or what's your experiences with getting political impact or impact on social policy from your research?
Well, so I'll go back to the maternal mortality example at the very beginning of my career. That was really quite dramatically a dramatic change in global health, in the way that data was collected, the way that programs were structured, et cetera. And I worked with Deborah Main, who is an epidemiologist, and argued with her way back before there were general comments, et cetera, that emergency obstetric care had to be a core obligation, because without emergency obstetric care, women die. That became part of human rights law and has been further elaborated. Since then, we just had a case in Uganda yesterday where finally the Petition 16 case was heard, and they won it after several appeals, establishing a right to maternal health care in Uganda, which is a very low resource country. So that has had, I would say, in the whole sort of, nothing is one shot, but over time that has had quite a significant impact, and in some ways has had inadvertent negative consequences too. I would say the work around HIV and intellectual property has also had quite a significant impact. I've done a lot of work on obstetric violence and sexual and reproductive health and rights and abortion rights in Latin America, with the, you know, the green wave that has swept Latin America. So I think all of those things have had have resulted in legal reform, have resulted in changes in budgeting and funding, and probably above all, and I'll keep coming back to this, it has resulted in changes in the way people think. When I started, it was insane to say that, in fact, I was told I was insane repeatedly, to think that a woman could have a right to go through pregnancy and childbirth safely. Now that is pretty much taken for granted as a minimum obligation of states in a modern democracy and health system. So I think it is important for young researchers to think outside the box, to ask the questions about what will make really significant, dramatic changes and not just accept the status quo. Thomas Kuhn famously said that it's not a surprise that it's young people, it's people who are coming to a field, who think in ways that are not the traditional orthodoxies and are able to be visionaries and make changes.
Yeah, that's very inspiring. Thank you for sharing that. Before I quit, I just wanted to ask you one last question about that. You have made some research related to the universal health coverage and sustainable development goals. Is there anything about that that you would like to share here that is relevant for this issue, or?
Well, I think as Ulla Fritschoff pointed out, there's, we're not on a path to meet the goals by 2030, and there will be a lot of inequity. I think COVID is causing enormous retrogression that we'll only see the full impacts of probably actually for quite a while, but the immediate impacts on tuberculosis, on vaccinations, etc. I mean, in Partners in Health, where we run programs on the ground, we see this all the time of what is being displaced, funding for this and that. We're desperately trying to get enough oxygen to Africa now.
Yeah, exactly. Okay, are there any other comments that you or Alicia would like to give to each other?
No, maybe I would just like to add that I think the difference between Alicia and me illustrates very well the need for having the need for different perspectives on the same issues. And me as a medical doctor will have very different ideas on what are the causes and what can be done than a legal scholar like Alicia. She is reminding us about the importance of institutions, of legal frameworks. So I think working together is important to broaden your perspective and improve your understanding of these fundamental challenges.
Yeah,
I would absolutely echo that. I don't think we can meet the challenges that face us without working across fields and disciplines.
okay. We'll take that with us. Okay, so now we open to questions from the audience. Are there any questions to this panel? Lisa? Huh.
I don't have to go first. I've learned through experience that it's always smart to raise your hand first, because then you're. So I actually have a question to both of you, and due to you both have a very intimate knowledge of WHO, and you know the law, and you know the medics part of it. I'm concerned about the politics of it. I'm concerned about us living in a world where the global order that we knew, with kind of a unilateral, like a one superpower, the US, and Western powers kind of giving, what can I say, sort of steering the, world institutions like WHO. This is up for grabs. This is not really going on anymore. And they're just like, we don't really know what's going to happen, but there are like multiple countries fighting for this global hegemony. There's Russia, there's China, there's God knows what. But so what happens And in this country, what is happening now? And what kind of challenges are we facing? And I want to direct. This is my big worry for sort of where the world is going. But how is this affecting WHO as we speak? And how is it affecting how WHO is dealing with COVID? And with this vaccine nationalization debate, to what extent do we have any do we have global police in a sense, policing this issue, or is it total anarchy and nationalism? And what are your, so that's my worry. And my questions are, what are the possibilities? What are the options? And what are your fears? So maybe you want to start with the fears and go to the happy side.
Should I start?
Yeah.
Yeah. Yeah, okay. So very, very quickly from me first then, I think this idea of a world ruled by rules and institutions, a world order, never was a reality, but it's even weaker now. And we see that with WHO losing support from the US. Gates Foundation is one of the biggest contributor, a private philanthropist. And we shouldn't overestimate the role of a UN organization like WHO. So my response would be that we have to also participate in global deliberations and make our voices heard. And interestingly, when you think about the COVID situation and the vaccines, some of the companies have expressed that they are willing to share equitably vaccines for the world. And one contribution could be to help them think about this and support those kind of initiatives. But we shouldn't have this illusion that there is a global mechanism for allocating anything in a fair way.
Alicia, would you like to add something? Or?
I totally agree with that. I totally agree with that, and I think the dichotomy that has been set up in most debates between it is horrible that the United States has backed out of the WHO and we need to support the global order. Of course we need to support the global order, but the WHO has been weakened for a very long time, and institutions for global health have been corroded by corporate influence and democratic influences of philanthrocapitalism. So I think we need to be wary, and I like Ulla Fritjof's articulation of that very much.
Okay.
Hi, can you hear me?
Yes.
Friends, it's so nice to be part of this webinar. I wish I were in Bergen and in Cambridge instead of where I am. So just to follow on what Lisa raised and what both Ulla Fritjof and Ellie were talking about, could you go into a little more details about the behavior of pharmaceutical companies and name names? Like who are the good guys who are really like putting their IP and other investments aside and saying, hey, go ahead, world, manufacture, and who are the ones who are really playing into proprietary interests and profit?
Would you like to start?
I don't think I can name the good guys. I think there are differences between the companies, but what I hear from my colleagues and other discussions is that the race towards finding an effective vaccine is something that has become an issue of prestige for these companies. It's not about profit maximization, at least for some of them. So the hope is, at least, and I think Moderna is one of the companies that have explicitly said that they would not do it for profit, basically, but are committed to equitable distribution. So at least there are some good examples there. I think the strong influence here will be from the interest of politicians and country leaders who will fight for their populations. And like in Yeah, so I think those agreements and the legal structure that make it possible for countries to make agreement even before the vaccine is developed for getting access to a large share of these vaccines is the major problem here. I have a lot of critical words to say about the pharmaceutical industry, but I hope and think at least there are some decent companies out there just in this race for saving lives.
So my own 2 cents would be that Moderna is not a good guy. Moderna has taken billions of taxpayer dollars, and it is absolutely out for profit. Doses will be on the order of $50, $60, $70. Whereas AstraZeneca and its collaboration with Oxford, I'm not saying that it's a good guy, don't get me wrong, but it is making its research available, and the doses will be closer to $3 or $4. It's going to be manufactured in Argentina and finished in Mexico, so that at least some middle-income countries can get access to a vaccine at the same time. It's very likely that we'll have multiple vaccine candidates, and it's So some of them will have different effects, including whether if you're vaccinated, you confer some immunity on people with whom you're in contact immediately. But so it may be that people have get different vaccinations, and it's for a while until the world sorts out which is most effective. But surprisingly, Mindy, for example, the Chinese are not planning to be very generous or relinquish their IP claim for their leading vaccine candidate. Yeah.
So I also have a question from Mulu, who's asking about the difference between the Sustainable Development Goals and the Millennium Development Goals, asking if the more human rights orientation in the SDG compared to the MDGs has brought any difference so far.
Alicia, this is your field.
So I would point them to Philip Alston's latest report on the SDGs. I don't think so. I mean, I think the Agenda 2030 and the shift in power that it reflected, that it was not a club of donors, that it was really the G77, and that it was a transformative declaration with interconnected universal goals, inequality as opposed to poverty, etc. That was hopeful and good, but it quickly became something else, again, because it was pasted on to the neoliberal architecture of the world. And once that happened, it was very unlikely that the Sustainable Development Goals were going to be transformative. And in some respects, the indicators have been terrible and reductivist, etc. I think UHC, which Ulla and I both work on, is potentially really an important mobilizing mechanism to focus on health systems as part of the fabric of democratic societies instead of vertical diseases as the MDGs focused on. But we'll see, you know, how far that goes. I think we've seen in COVID that stopping the contagion has already displaced a lot of other issues in health systems that are underfunded, fragile already in many places, including in the United States.
Okay. Are there more questions or, yeah?
Yeah, thank you. I'm working in the field of climate justice, and I find a lot of similarities. So I have two questions, if there's enough time. One is, how do you combine equitable care and reflections around equitable prevention or exposure to whether it's COVID or other public health issues. And the second question, perhaps related more to the beginning of the discussion on how do you combine thinking on giving priority access or equitable access on the basis of individuals, so more vulnerable individuals, versus access to vulnerable societies. And then how do you define society and the contribution that the vaccine, for instance, can have on the society? So whether you prioritize saving individuals or the most individuals or their impact on society.
Yeah, two very good questions that are hard to answer. There are a lot of similarities to climate change thinking and thinking about the here and now and the future. And I think for health, it's very often the case that it would be smarter and better for society to prevent future health loss and disease and mortality. But we tend to focus on the here and now, and we tend to focus on the acutely ill individuals. So that's a tension in medicine between those who work with at the bedside with individual patients with a lot of compassion and those who move to the public health arena, where you probably can see more impact of what you do, but it's not that visible. So saving statistical lives is not as interesting as saving a person in front of you. So that's difficult. But the example that Alicia mentioned about preventing maternal deaths, for instance, it was that in that case it was opposite. We thought that it would be better to test women before they and screen them before giving birth, and treatment when they have complications was not thought of as that important. So it's finding this intricate balance between preventing and helping those who are in need on that issue. Maybe Alicia, would you like to try to answer the second question?
What was the second question again? I can't hear all the, can you repeat the second question?
Yeah, weighing of individuals versus populations. Is that correct?
Yes, so I got an answer. Can you repeat the question?
In terms of vulnerable individuals within countries and countries that have less capacity, I think that's a really, really complicated question. And I mean, ideally, in a public health situation, you would want to do exactly what Ulla Kirchhoff set out, which was, you know, say that, okay, there's a social contract in this country, and that gives you priority for a certain number of people, but say health workers or other people who are vulnerable for socially constructed reasons should get priority over, you know, a young, healthy population or something like that. Ideally, you would want to have some kind of deliberation on that. But unfortunately, that's rarely the way the world works. On the public health versus treatment, I mean, in the United States, and this is something that's very close to home because Partners in Health does this, we have no public health spending. This is like zero. All of the billions of dollars that have been funneled into the vaccine, which is going to be a magic bullet, and probably go to the wealthiest first and make these pharmaceutical companies and hospital, you know, insurance even more money. But saving people who are dying before the vaccine comes out or who become very ill is of such low priority in this country because we just don't have public health systems. And so I think in general, the countries that have fared better invest in public health, invest in primary care, have more egalitarian institutions so that you are confident that you can, one, get access to the healthcare system and treatment if you need it without going bankrupt, 2, you won't lose your employment. 3, if you are sick and need to be isolated or quarantined, that will be okay. You know, there's no place to be isolated or quarantined in many countries. So I think that there are economic and legal factors that structure whether we focus on biomedical treatment or whether we focus on social factors and public health.
Okay, thank you. Was that the last question, or? Okay, yeah. So maybe you should quit. Okay. So I guess we're done. So thanks to everyone, and especially to Alicia and Orleta. Thank you very much for participating. It was very interesting to hear your opinions on this. Thank you.